Uh, so we will begin today's session. Today's session is on abdomen. And as you all know, it's not easy to cover the whole topic in 1 or 2 hours. We need 4 or 5 hours minimum to complete the entire session. But still, I'll try my level best to make it clear the important aspects and the important questions which you can expect in the coming entrance examinations. The favorite areas for the examiners. So with this, let me begin today's session. Usually, I prefer to discuss the topic with questions, with clinical questions, because if it is NEET or next, you will be having clinical questions and you will be asked to answer questions from anatomy through the clinical questions. So I always want you to have a clinical point of view when you answer the anatomy questions, which will be easy for you then. Let's see the first question. A 56-year-old man is jaundiced and has severe abdominal pain. He is diagnosed with a malignant neoplasm of the head of pancreas. Pain from this problem would be referred to which of the following dermatomes? So though the question seems longer, the answer is, what they are asking is, we need to know which are the nerve fibers which are carrying the pain sensation from the pancreas. So, can anyone answer? Option A is T5 to T9, B is T11, C is T12, and D is L1 to L2. So, let's see the answer. The answer to this question is T5 to T9. So, let's see how are these dermatomes distributed. For this, you need to have an idea about the autonomic nerve system. Autonomic nervous system consists of sympathetic and parasympathetic. So sympathetic, we usually say it as thoracolumbar outflow, and parasympathetic, we usually say it as craniosacral outflow. So this is the first and the foremost thing. This concept, if you make it clear, it will be easy for you to answer many of the questions asked in the entrance examinations. So sympathetic is thoracolumbar and parasympathetic is craniosacral. So sympathetic information usually comes from T1 to L2 spinal segments. The outflow, the sympathetic outflow which comes from the brain comes out of the spinal cord through the gateway, that is from T1 to L2. Whereas the parasympathetic is from craniosacral. That means it comes through the vagus as well as through the pelvic splanchnic nerves. So, talking about the sympathetic nerves, we have the nerves arranged like T1 to T4, we call it as cardiopulmonary. Then T5 to T12, we call it as thoracic. And lumbar, we have from L1 to L2. Whereas the parasympathetic, that is craniosacral, you can see the cranial component, the vagus nerve, and the sacral component, the pelvic splanchnic nerves. Okay, so these are the two components which carry the parasympathetic information. Now, talking about the splanchnic nerves, which are the splanchnic nerves you know about? Can you tell me which are the splanchnic nerves you know about? One is thoracic splanchnic nerves. Any other splanchnic nerves you know in the body? You have the thoracic splanchnic nerves. Which are the other splanchnic nerves? You have the lumbar splanchnic nerves. Then you have the pelvic splanchnic nerves. So whenever you hear splanchnic nerves, my question is, are all these splanchnic nerves sympathetic or parasympathetic? Or is there any exception? So these are some of the important concepts which you should be clear with. So which are the splanchnic nerves which you call as parasympathetic? Very good. Pelvic splanchnic nerves are parasympathetic, whereas thoracic and lumbar are sympathetic. Though you call it as splanchnic, thoracic and lumbar are sympathetic, and pelvic splanchnic nerves are parasympathetic. That is again one important concept. So let's see the thoracic splanchnic nerves first. We have T5 to T9, known as greater splanchnic nerve. Okay, so T5 to T9, you call it as greater splanchnic nerve that pierce the crus of the diaphragm, and their main area of supply is foregut. Whereas the remaining two, T10, T11, you call it as lesser splanchnic nerve. Again, they pierce the crus of diaphragm. And the last one is T12, the least splanchnic nerve, and they pierce the medial arcuate ligament. So we can see that the lesser splanchnic and least splanchnic, they supply the midgut, hindgut, and the pelvic viscera. Okay, so this is how the thoracic splanchnic nerves are supplying the GIT. Greater splanchnic, foregut, lesser splanchnic and least splanchnic, they supply the midgut, hindgut and pelvic viscera. So that's the reason why we got T5 to T9 supplying or receiving the pain impulses from the pancreas. Hope the answer is clear for you. Now coming to the next question. A 56-year-old alcoholic has severe portal hypertension. Which of the following veins is most likely enlarged in this condition? Portal hypertension, and which of the following vein is involved? Is it testicular vein? Is it hepatic vein? Is it renal vein? Or is it splenic vein? Whenever you think about portal hypertension, you have to think about the tributaries of the portal vein. So what can be the answer? A testicular, B hepatic, C renal, and D splenic. The question might be misleading because it is said alcoholic, but they are asking about the vein dilated in portal hypertension. So can I get the answer? The answer is splenic vein. So the reason is you need to know how a portal vein is formed. A portal vein is formed by the union of splenic vein and superior mesenteric vein. These are the two major veins leading to the formation of portal vein. You have the splenic vein, you have the superior mesenteric vein, and these are united to form the portal vein behind the neck of pancreas. Okay, and you can see the portal vein, and behind that you can see the inferior vena cava. Now, you can see the inferior mesenteric vein as the tributary of the splenic vein. Though it's not directly taking part in the formation of portal vein, you have the inferior mesenteric vein draining into splenic vein. Now, what about the other veins mentioned in the options? The other veins mentioned are, you can see the left renal vein here, you can see the hepatic veins here, you can see the gonadal veins. All these are draining into the inferior vena cava. So all these belong to the vena caval system, whereas the other one was belonging to the portal system. So whenever you get a question like which of the veins are dilated in a portal hypertension, you think about which are the veins forming the tributaries for the portal system. Okay, that is how you can solve the question. So all these veins are draining into inferior vena cava. The next question is, the neurovascular plane in the anterior abdominal wall lies between. So between which all layers you have the neurovascular bundle, whether it is between the subcutaneous tissue and the external oblique muscle, whether it is between external and internal oblique, whether it is between the internal oblique and transverse abdominis, or between the transverse abdominis and peritoneum. In which plane you get the neurovascular bundle in the anterior abdominal wall. So this is actually a question related to rectus sheath. Now can you answer? Which of the following option do you have? Yes, the answer is between the internal oblique and transverse abdominis. You can see the rectus abdominis in the anterior abdominal wall. So when we talk about the rectus abdominis, the formation, we have different theories, but still the most commonly accepted theory says, or we discuss the rectus under three headings. One, above the costal margin. The next one, between the costal margin and the arcuate line, and the Third one is below the arcuate line. So above the costal margin, above the arcuate line, and below the arcuate line. These are the three headings under which we discuss the rectus abdominis, because the formation of the aponeurosis is different at three levels. And above the arcuate line, you can see that the external oblique is joining with the anterior layer of internal oblique, and behind the rectus abdominis we have the internal oblique and posterior layer of internal oblique along with the transverse abdominis. Okay, and when we go below the arcuate line, you can see that all these three aponeuroses are going in front of the rectus abdominis, and you can see the neurovascular bundle lying between the rectus abdominis and the fascia transversalis. So there is no option like this, but the option which we have among the four is between the internal oblique and transverse abdominis. So the neurovascular bundle can either lie between the internal oblique and transverse abdominis, or between the rectus and fascia transversalis. It is not between the fascia transversalis and the parietal peritoneum. So these two options you can go for. They haven't specified whether it is above arcuate line or below arcuate line or above costal margin. But still you can have two options, either between the internal oblique and transverse abdominis if it is above the arcuate line, and if it is below the arcuate line, it should be between the rectus abdominis and fascia transversalis. So among the options which we have, the option between the internal oblique and transverse abdominis is the one which we can opt for. Okay. Now going to the next question. So for repairing a duodenal ulcer as part of the operation, the surgeon reflects the stomach and first part of duodenum upwards, which exposes the area posterior to them. Location of which of the following structures is now possible behind the first part of duodenum? They are just asking what is the structure lying behind the first part of duodenum. It is just a relation which is asked, though the question seems longer. The options which we have here are the gastroduodenal artery, hepatic vein, left renal vein, superior mesenteric artery. Which of the following structures are lying behind the first part of duodenum? That is the question. So what can be the answer? I think I have already shown the answer. The answer here is gastroduodenal artery. So let's see how this gastroduodenal artery is lying here. You can see the relation. This is the first part of duodenum, second part of duodenum, third part, and the fourth part. So which of the artery is lying behind the first part, and which of the artery is lying anterior to the third part? Can someone say which of the artery is lying behind the first part? Name the artery. Name the artery lying behind the first part of duodenum. Can someone say the name of the artery? That is a question which is asked. Name the artery. It is the gastroduodenal artery. So gastroduodenal artery is a branch of, can someone say? Gastroduodenal artery, is it a direct branch of celiac trunk or is an indirect branch? It is not actually a direct branch, because which are the three direct branches of celiac trunk? You have the three branches of celiac trunk as left gastric artery. Yes, very good, Nevin. Left gastric artery. Then which are the other two branches of the celiac trunk? The other two branches of the celiac trunk are splenic artery and common hepatic artery. Okay, so very good. So these are the three branches, and out of these three branches, left gastric, splenic, and hepatic artery, gastroduodenal artery arises from which of these three arteries? That is my question. You can see an artery curving and going up, common hepatic artery. Very good. So you can see an artery going up, and it is giving an artery downwards. That is the gastroduodenal artery. Okay, and what happens to the gastroduodenal artery? The gastroduodenal artery is lying behind the first part of duodenum, and it gives off the superior pancreaticoduodenal, which divides into an anterior and posterior branch. You can see the superior pancreaticoduodenal, which is dividing into anterior and posterior branch. And in front of the third part, you have the artery, that is the superior mesenteric artery, which is giving off the inferior pancreaticoduodenal, which further divides into anterior and posterior branch. So these two branches, the superior pancreaticoduodenal coming from the gastroduodenal and the inferior pancreaticoduodenal artery coming from the superior mesenteric artery, they anastomose, and that anastomotic arcade will be supplying the duodenum. So the two important aspects which you should be knowing here is, one, the gastroduodenal artery lies behind the first part of duodenum, and the superior mesenteric artery will be lying in front of the third part of duodenum. Superior mesenteric artery is a very favorite question for most of the examiners, whether be it in anatomy or in surgery. You will get a lot of questions from superior mesenteric artery. Now, coming to the other structures seen in proximity, you can see the portal vein, which is formed by the union of splenic and superior mesenteric vein. Now, prepyloric vein of Mayo. Prepyloric vein of Mayo, how is it clinically related? What is the significance of prepyloric vein of Mayo? Can someone say the clinical significance of knowing the position of prepyloric vein of Mayo? Will it help the surgeons to identify any part? It's again asked mostly in surgery. Importance of prepyloric vein of Mayo. What is the importance? If you identify that that vein, you can identify what? So it's actually a tributary of right gastric vein. It signifies the junction of the pylorus and first part of duodenum, otherwise known as lethargic vein. Okay, so prepyloric vein of Mayo, if you can identify that, you can identify the junction of pylorus and the first part of duodenum. Now, coming to the next question, a pediatrician discovers a mass in the child's right inguinal region. Okay, and the mass is extending from just above the midpoint of the inguinal ligament to a point above and medial to the pubic tubercle. Which of the following best describes what the physician has identified? So it is a child, 4-year-old child, and there is a swelling. From the question itself, you can say what it is, because the position is medial to the pubic tubercle, above and medial to the pubic tubercle. Whether it is enlarged lymph node, whether it is undescended testis, whether it is direct inguinal hernia, and whether it is indirect inguinal hernia. What can be the answer? The answer is indirect inguinal hernia. Yes, undescended testis is actually put in before the indirect inguinal hernia, because most of you will pick that answer. Undescended testis usually won't present at this age, 4-year-old boy. Okay, so that is how you come to a conclusion whether it is undescended testis or indirect inguinal hernia. So let's see the position. You have the pubic tubercle here, and any swelling above and medial, it is actually coming out through the superficial inguinal ring. You have two rings between the canal. You have the superficial inguinal ring as well as the deep inguinal ring. Superficial inguinal ring is seen actually above and medial to the pubic tubercle. Okay, so this is a case of indirect inguinal hernia. So this is the position of deep inguinal ring. Now, what is this? This is actually below and lateral. That is the femoral hernia. So that is how you differentiate between inguinal, indirect inguinal hernia as well as femoral hernia. Now, this is just an anatomy of the inguinal ligament, the rings and the femoral sheath, how all these structures are related. What is the relation between all these structures? Sometimes you will get a diagram or image like this, and you will get pointers asking what is the structure. Okay, so first you can see the inguinal ligament extending from the anterior superior iliac spine to the pubic tubercle, and you can see the ring, superficial inguinal ring as well as the deep inguinal ring. Now, the structures which they usually ask to identify is, first you can get a pointer at the inguinal ligament. Then one of the favorite question is the lacunar ligament, which is actually forming the medial wall of the femoral canal. So the femoral sheath has got 3 compartments. And one interesting thing is you can see that the nerve is outside the femoral sheath. In the lateral most you have the artery, then you have the vein, and the medial most is called the femoral canal. And one of the boundary of the femoral canal is the lacunar ligament. The medial most, the triangular portion is the lacunar ligament. And you can see the extension of the lacunar ligament as along the pecten as the pectineal ligament. Okay. So these are some of the pointers, favorite pointers in most of the exams. Can someone identify this image? What is this image? Can someone? How can it be undescended testis? The testis is already there in the scrotal sac. You can see it correctly. Something else is herniating. What is this? A finger-like thing. What can it be? Finger-like protrusion. If you feel it like appendix, what is the part which you see here? Because that finger-like thing is attached, it's not attached to cecum, right? So then what can it be? So the answer is, it is known as Litter's hernia, and it is the Meckel's diverticulum which is herniating. Okay, if you have the Meckel's diverticulum herniating, you call that as Litter's hernia. Now the next thing is, which is the true statement about the deep inguinal ring? It is a gap in the transverse abdominis muscle. It lies lateral to the inferior epigastric artery. It transmits the paminiform plexus of veins. It is a site of direct inguinal hernia. What can be the answer? Can someone say? They are asking for the true statement. What can be the answer? I think someone is getting confused between the direct and indirect inguinal hernia. Direct inguinal hernia never comes through the rings. Indirect inguinal hernia comes through the rings. And yes, some of you are getting confused with the first option. They are saying about transverse abdominis muscle. So deep inguinal ring is a defect in what? Which structure? Can someone answer that? Deep inguinal ring is a defect in fascia transversalis. It's not in transverse abdominis muscle layer. Okay, so that is again a misleading option. So the answer here is, the deep inguinal ring is lateral to the inferior epigastric artery. Okay, so this is how the relation looks like. You can see the inferior epigastric artery and the ring is actually lying lateral to it. Okay, and it is a defect in transversalis fascia or fascia transversalis. So there is a triangle formed by inferior epigastric artery, rectus abdominis, and below the inguinal canal or inguinal ligament. What do you call that triangle? Can someone answer that? What do you call the triangle bounded by inferior epigastric artery, rectus abdominis, and inguinal ligament? Yes, very good. So that triangle is known as Hasselbalch's triangle or inguinal triangle. And another name given for the inguinal ligament is Oppert's ligament. Why I'm stressing on these things is, sometimes in the options you might be knowing all these boundaries, but it will be replaced by its synonyms. Okay, so then you have to know the synonyms as well. Now, one of the option was, at the deep inguinal ring, you will get the paminiform plexus of veins. So how are these veins transmitted through the inguinal canal? You should be knowing that. So papilliform plexus of veins are not related to the deep inguinal ring. So you can see that the papilliform plexus of veins arising from the testis at the superficial inguinal ring, they converge and form 4 veins, and along the canal they become 2 veins, and at its exit from the canal at the deep inguinal ring, you have the testicular vein formed. Okay, among the options, the papilliform plexus of veins were mentioned at the deep inguinal ring. So we won't get the papilliform plexus of veins as such in the deep inguinal ring. They will be converging at the superficial into 4 veins. Along the canal, you get 2 veins, and at the deep inguinal ring, you have just 1 vein, the testicular vein formed. Now, coming to the next question. There's history of bloating, nausea and vomiting, 56-year-old patient. An upper GI radiological examination using contrast media reveals an obstruction of the third part of the duodenum. Okay, so the question is, there is an obstruction in the third part of the duodenum, and it seems to be due to an arterial aneurysm. So, an arterial aneurysm causing obstruction for the third part of duodenum. That is just the question. And which of the following artery is the most likely site of aneurysm? So you need to know which is the artery lying in close relation with the third part of duodenum. The options are inferior mesenteric artery, right renal artery, superior mesenteric artery, celiac artery. All these arteries are related to duodenum, but we have already discussed the relation of the third part and the first part. So third part is actually related to, yes, most of you were answering it, superior mesenteric artery. We have already seen this figure before. The first part, posteriorly, it is related to the gastroduodenal artery, and third part, anteriorly, it is related to superior mesenteric artery. And the syndrome is known as Wilkie syndrome or cast syndrome. Obstruction caused by the superior mesenteric artery aneurysm for the third part of duodenum. And can someone answer this syndrome? I have shown an image in the inset. Can someone answer? Which are the vessels involved and what is the syndrome? What do you call the syndrome? This is a favorite question for surgeons. Very good. Someone has answered it correctly. It is known as nutcracker's syndrome. Okay. So what do you mean by nutcracker syndrome? You can see superior mesenteric artery. You can see the abdominal aorta. And which is the vessel lying between the superior mesenteric artery and abdominal aorta? Can someone say? The pointer is on which vessel? Very easy, right? In nutcracker syndrome, yes, left renal vein. So left renal vein is actually crushed between the superior mesenteric artery and abdominal aorta, like how you crack a nut. So that is known as nutcracker syndrome. Hope all of you are here. Next question, which of the following is the most dependent region of the peritoneal cavity in supine position? In supine position, which is the most dependent, whether it is hepatorenal pouch of Morrison, rectovesical pouch, utrovesical pouch, rectouterine pouch, or pouch of Douglas. In supine position. Yes, I think most of you know the answer. It is the hepatorenal pouch of Morrison. So in supine position, when you compare these two, it is the hepatorenal pouch of Morrison. So that's the reason why hepatorenal means between the liver and the kidney. And that is the reason why you make the person sit in a slanting position, especially soon after surgeries and all, when you expect a fluid collection. Why? Because when there is collection here, it might irritate the diaphragm. Okay, so when you make the person sit up, then the most dependent position will be the pouch of Douglas, otherwise the rectouterine or rectovesical pouch. Rectouterine in case of females and rectovesical pouch in case of males. So that concept also you should be knowing, pouch of Douglas. it is rectouterine in females between the rectum and uterus, but in males you don't have the uterus and instead you have the bladder. Now something about the supracholic and infracholic compartment. You can see that the transverse colon is the plane which divides these two compartments as supracholic and infracholic compartment. One of the favorite question is, the hepatorenal pouch is actually continuing with the right paracholic gutter, whereas when you see on the left side, the left supracholic compartment is not in continuity with the left paracholic gutter. So one structure is actually separating the left supracholic compartment from the left paracholic gutter. So which is the structure separating that interfering with the continuity? Can someone identify the structure which is hindering the continuity between the left supracholic compartment and left paracholic gutter? It is already labeled there. Very good. Phrenicocholic ligament. Okay, so you can see the phrenicocholic ligament, and because of its presence, the left supracholic compartment is not in continuity with the left paracholic gutter, whereas on the right side, you can see the hepatorenal pouch, the right supracholic compartment in continuity with the right paracholic gutter. And when you see the infracholic compartments, the right and left within the colon, you can see one is open whereas the other is closed. Which one is open? Right or left infracholic compartment? Which one is open? From the diagram itself, you can very well make out. Right or left? Yes, left is open whereas right is closed. So these are the two important concepts which you should be knowing when you think about the supracholic and infracholic compartments. Now, a 62-year-old woman has a venogram that shows a blockage in the left renal vein where it crosses anterior to the aorta. Additional tests indicate that the occlusion is caused by an arterial aneurysm. Which of the following arteries is most likely location of the aneurysm? They have mentioned the left renal vein. The arteries given are celiac trunk, splenic artery, superior mesenteric artery, and inferior mesenteric artery. What can be the answer? We have already discussed it. What can be the answer? Yes, most of you have answered it. Superior mesenteric artery, the nutcracker syndrome, which we have already discussed. Okay, so you can see the left renal vein, you can see the superior mesenteric artery and the abdominal aorta. And other arteries which are coming from the aorta are celiac trunk, it is high above, and inferior mesenteric artery is low below. So the artery which is in relation with the left renal vein is superior mesenteric artery. Now the next is, the following veins cross the midline from left to right, except. You have the left renal vein, left brachiocephalic vein, hemiazygos, accessory hemiazygos, superior mesenteric. The question is, which is the vein which crosses from the left side to the right side? Can I get the answer? Except. The question is except. Please think again. I am not getting a correct answer. Yes, we will see how it is. I think one or two has answered it correctly. It is a superior mesenteric vein. So that green line represents the midline. Okay, and now you have a look at the veins which were already mentioned. Which is this vein? Can someone say which is this vein? We can see the left brachiocephalic vein. You can see the accessory hemiazygos, left renal vein. All these veins are actually crossing from left to right, whereas the superior mesenteric vein is exactly lying on one side. It's not crossing from left to right. The next is middle suprarenal artery is a branch of middle suprarenal artery. So you know suprarenal arteries, you have how many suprarenal arteries are there? 1, 2 or 3? Suprarenal arteries, how many are there? 1, 2 or 3? Suprarenal arteries, how many suprarenal arteries are there? If you have middle, then obviously you should have one above and one below. That is the clue, right? So there are 3 suprarenal arteries. So middle is actually coming from aorta. So this is how you get the suprarenal arteries. The superior one, the middle one, and the inferior one. So superior comes from, can someone read the answer? Superior suprarenal artery comes from which artery? Is giving rise to the superior suprarenal artery. Inferior phrenic, very good. Now you have the middle coming from superior, you have the inferior phrenic artery. Middle suprarenal arises from the aorta, and inferior suprarenal is actually coming from the renal artery. Okay, so these are the 3 different arteries: superior suprarenal, middle suprarenal, and inferior suprarenal. They are having 3 different origins. One is inferior phrenic, second one is aorta, and the third one is renal. So this is again a favorite question. They will be frequently asking the suprarenal arteries and the branches from which they are arising. Okay. Now, what about the veins? You should be knowing about the vein as well. So one suprarenal vein, they are coming from right and left. You call it as right suprarenal vein and left suprarenal vein, but their termination is different, isn't it? You can see on the right side, the right suprarenal vein is directly draining into inferior vena cava, whereas the left suprarenal vein, it is again draining into inferior vena cava, but indirectly. It is actually draining into left renal vein along with the other vein which is draining into left renal vein. Can someone answer from the figure? Which is the other vein draining into left renal vein? Very good, left gonadal vein. Okay, so left gonadal vein and left suprarenal vein, they are draining into left renal vein and then draining into inferior vena cava. Now, talking about the adrenal cortex and adrenal medulla, just I would like to add something. You know, the adrenal medulla, they are actually having the preganglionic through the thoracic splanchnic, and the adrenal medulla is made up of chromaffin cells, which are actually considered as postganglionic fibers. Okay. And what do they secrete? Chromaffin cells. Can someone say? It is there in the figure. Adrenal medulla chromaffin cells, which are considered as postganglionic, they secrete what? It is given in figure. Very, very important. They give off adrenal and noradrenal. Very good. And what about the cortical region, the neuronal component? You have the ACTH, which are actually produced in the adenohypophysis. Now, the next question is, right testicular vein drains into. Right testicular vein. So the 2 gonadal veins. We just mentioned that in the previous slide. Right testicular vein, whether it is draining into inferior vena cava or left renal vein or left common iliac or left internal iliac, it is actually very easy. There is no confusion, right? It is right on the right side. So the answer should be inferior vena cava. So you can see the gonadal arteries, the testicular arteries are arising from which artery? Gonadal arteries are direct branches coming from. Can someone answer? From the figure itself, you can see the testicular arteries arising from abdominal aorta. Very good. But when you see the veins on the right side and left side, though they are draining into inferior vena cava, on the right side, you can see that it is directly draining into inferior vena cava, whereas on the left side, we have the left renal vein into which you have the testicular veins draining at right angles. And that's the reason why we expect varicocele most commonly on the left side because of this pattern of drainage. Now, the next question. A 42-year-old woman is undergoing liver transplantation. During the procedure, the suture immediately posterior to the epiploic foramen is damaged, causing significant bleeding. Which of the following vessels is most likely injured? They are asking simply for the posterior relation of epiploic foramen. And options are abdominal aorta, portal vein, inferior vena cava, and common hepatic artery. Most of them are actually in a way seen in relation with the epiploic foramen, but the posterior relation is very good. All of you know it. It is the inferior vena cava. So the figure is showing the fingers in the epiploic foramen and which is the structure between the fingers. Can someone answer? Which is the structure that person is holding between the fingers? All these, why I'm stressing is, these can be the images with pointers asking, is it lesser sac? It is omentum. Which omentum? Lesser sac is a sac behind the stomach. Okay, it is a sac behind the stomach, whereas all the compartments seen in relation with the greater omentum is seen anterior to it, and that you call it as greater sac. So this yellow colored thing between the two fingers, you call it as lesser omentum. And what are the structures seen in relation with the epiploic foramen? Above, you have the caudate process. Below, you have the first part of duodenum. Anteriorly, it is actually the free margin of lesser omentum with its contents. Can someone say the contents of free margin of lesser omentum? Can you please mention the contents? 1, 2, 3. Yes. Portal vein, hepatic artery, and bile duct. Very good. So the anterior relation, it is the free margin of lesser omentum with its contents. And the posterior relation is the inferior vena cava. That was our question. Okay. So these important relations you should be knowing. If the question was structures injured anteriorly, it can be hepatic artery, portal vein, and bile duct. Now coming to the next question. Which of the following duodenal recess has a vascular fold as its boundary? So vascular fold means you have folds related to the duodenal recess, and one of the fold is having a vessel in it. So which is the fold having a vessel in it? That is the question. The options are superior, inferior, retroduodenal, and paraduodenal recess. So which recess is having a fold with a vessel in it? Can I get the answer? Whether it's superior, inferior, retroduodenal, or paraduodenal recess. Yes, someone has answered it correctly. Paraduodenal recess. So this is duodenum, and you can see the recess: superior recess, inferior recess, retroduodenal, that is behind the duodenum, and the paraduodenal recess. Okay. And in the paraduodenal recess, you can see the fold with the paraduodenal fold with the inferior mesenteric vein. So the vessel seen in relation with the fold is inferior mesenteric vein. And these recesses are sites for internal herniation. And internal herniation of the loops might result in intestinal obstruction. Okay. Now coming to the next question. The structures crossed by the root of mesentery are all except. You know, the root of mesentery actually is is aligned obliquely from left to right, and when it is attached to the posterior abdominal wall, it is actually crossing some of the important structures. The options are third part of duodenum, left psoas, abdominal aorta, inferior vena cava, and right ureter, which is not actually a structure crossed by the root of mesentery. That is a question. What can be the answer? Yes, some of you are having a doubt, but still you tried answering it very good. So it is not the left psoas, it is the right psoas. So you can see the extent of the root of mesentery from L2 to right sacroiliac joint, isn't it? It is actually aligned in an oblique manner, and you can see the psoas muscle. Of course, it is crossing the psoas, but it is the right psoas. It is not the left psoas. So let's see the structures one by one. The root of mesentery is actually a part of the greater sac, and the root is actually 6 inches long, whereas the free border where it contains the loops of small intestine, it is actually 6 to 7 meters. Okay, and the structures crossed are third part of duodenum. Then you have the abdominal aorta, then you have the inferior vena cava, then you have the right ureter, and you have the right psoas major. So all these structures are actually crossed by the root of mesentery. And of course, sometimes you might have an option that is right gonadal vessels too. So it is not the left psoas, it is the right psoas. Sometimes you might study the psoas and you might think like it is there in the option. Now, the next question is somewhat a tricky question. The following muscles are digastric in nature except sternocleidomastoid, superior oblique, omohyoid, digastric, suspensory ligament of Treitz. Can someone answer it? Which of the following? Exception. Let me see who will be answering it correctly. Not digastric. So someone has fell for the ligament. They have kept that ligament purposely so that most of you will opt it. You please read it again. It is to belly, digastric. Gastric means belly. And they have kept the option A as yes. Some of you got it. The exception is sternocleidomastoid. Sternocleidomastoid is not having two bellies but two heads. Okay. So let's see. Some of you were answering it as suspensory ligament of Treitz, but suspensory ligament of Treitz, it is also derived from two different muscle components. The superior aspect, it is actually derived from the diaphragm and it is made up of a skeletal muscle component, whereas the inferior aspect of the suspensory ligament is actually derived from the duodenum and it is having a smooth muscle component. So these two are actually considered as two bellies of the ligament. The next is perforating ulcer on the posterior wall of second part of duodenum damages abdominal aorta, ascending colon, superior mesenteric artery, right renal pelvis. Second part of duodenum, what is the posterior relation? Can someone answer it? Second part of duodenum, somebody is answering it thinking third part, and it is the posterior relation which is asked. It is not the anterior relation. Can someone answer it? If I get, yes, I'm getting the answer. It is the right renal pelvis. So you can see the second part of duodenum, the posterior relations. You have the right kidney, you have the right renal vessels, and a part of inferior vena cava. So In our option, we have the right renal pelvis. Okay. Now, when we think about duodenum, we know it is made up of 4 parts. What about the length of each part? The easiest way to think about the length is 2, 3, 4, and 1. 2, 3, 4, 1, what is the unit? When I say the length as 2, 3, 4, 1, what is the unit? 2, 3, 4, 1. First part, second part, third part, and fourth part. Very good. Inch. So 2 inches, first part, 3 inches, second part, 4 inches, third part, and 1 inch is fourth part. Okay. Or you can remember it in centimeters as well, but I prefer to remember it in inch. And you can see the 2 duodenal flexures, the superior duodenal flexure and inferior duodenal flexure on the right side and duodenal jejunal flexure on the left side. And the vertical extent is from L1 to L3. All these can be asked in different ways. And first part is more prone for peptic ulcer because of the presence of end arteries. Second part is actually well protected because it is in the paravertebral gutter, and it is into the second part. We all know the bile and pancreatic ducts open. What about the third part? Third part is the part which is lying most anteriorly. That is between the vertebral column and the anterior abdominal wall. So it is this part which is most vulnerable to injury. And the fourth part we have already seen, it is related to the duodenal recesses. Okay, so these are the important points related to each part. Now, coming to the next question, if superior mesenteric artery is occluded near its origin, which is likely to be ischemic if collaterals fail to develop? Whether it is the proximal duodenum, ileum, stomach, sigmoid colon. Can someone answer? Though the question looks complicated, they are asking which is the region supplied by the superior mesenteric artery. Now I think you can answer. Which is the region supplied by superior mesenteric artery? I think some of you are going in the wrong direction. Can you please think about the 3 major arteries supplying the GIT? You have the celiac trunk, you have the superior mesenteric artery, and you have the inferior mesenteric artery, right? So celiac trunk is actually supplying the foregut, superior mesenteric artery, the midgut, and the inferior mesenteric artery, the hindgut. Now, yes, now many of you are answering it. So let's see, it is ileum. So superior mesenteric artery, we know it has a concavity to the right side and a convexity to the left side. So what are the branches arising from the concavity? You can see the inferior pancreaticoduodenal, then you have the middle colic, right colic, ileocolic. All these are repeatedly asked. What is it a branch of? What is it? What is the exception, etc., etc. And from the left side, the convex portion, you have the jejunal and ileal branches. Okay, so with this knowledge, you can very well answer the question. The main thing which you should know is there are 3 main arteries: celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Celiac trunk is supplying the foregut, superior mesenteric the midgut, and inferior mesenteric artery the hindgut. So you can also look for the, if you are not aware of the branches of these arteries, you can just look for the derivatives, whether it is the foregut derivatives given or the midgut or the hindgut. Okay. So here it is the ileal branches. Hope it is clear for you. Now, the splenic and left renal vein. What is the significance of splenic and left renal vein? We have already mentioned it in relation with the superior mesenteric artery. Can someone say splenic and left renal vein and superior mesenteric artery? The sandwich. Okay, the splenic and left renal vein, they are actually sandwiching the superior mesenteric artery. Now, the next thing is the most common position of appendix. We all know the different positions of appendix: retrocecal, pelvic, pre-ileal, post-ileal. And some of the books, they do differ when we discuss about the clock positions, but still When we think about the most common position, they all are commenting the same. Yes, the answer is retrocecal. Okay, so retrocecal is the most common position. So let's have a look. When we think about appendix, it ranges from, the length ranges from 2 to 20 centimeters. On an average, you will get the length as 9 centimeter. The valve guarding the opening of appendix, you call it as valve of Gerlach. This is also asked. Now, you can see the different positions. Retrocecal is the most common position. And the second common position is the subcecal. And when we think about the splenic, you can see two options. Pre-ileal, if it is lying in front of ileum, and post-ileal. Can someone say which is the most dangerous position, pre-ileal or post-ileal? Among the two splenic options, which is considered as dangerous, whether it is pre-ileal or post-ileal? Why did you say, Nitin, I think, why did you say it as post-ileal? What is the danger you expect if it is post-ileal? Can you explain? The answer is pre-ileal. Why? Because if there is any appendicitis, it will be in communication with the whole of peritoneum, the greater sac. Okay, so pre-ileal is actually considered to be dangerous. So these are the different positions. Retrocolic is otherwise called 12 o'clock position. Paracolic is 11 o'clock position. Mid-inguinal or subcecal, it is 6 o'clock. Pelvic is 4 o'clock. Promontoric is 3 o'clock. And the splenic is pre-ileal or post-ileal, it is 2 o'clock position. So these are some of the important positions, and you need to know the different names belonging to each clock position. Okay. Now, the next thing is, which is considered as a guide to identify appendix in the living? Anterior tinea coli, appendices epiploicae, ileocecal artery, blind end of the rectum. Because when you open the peritoneal cavity, even in the cadaver, it's not easy to get the appendix located. So if you are dealing with a live person, you need to identify the appendix faster, isn't it? You cannot simply go and see. Why pre-ileal is dangerous? Somebody is asking it. Pre-ileal means it is opening into the peritoneal cavity. Okay, the greater sac. So if there is any appendicitis, it might rupture and it might lead to generalized peritonitis. That is why pre-ileal is considered dangerous. So coming back to this question, which structure will help the surgeon to identify the position of appendix? If you trace that structure, that will help, or that will lead you to the appendix. Or else you will have to search for appendix everywhere around the cecum. Appendices epiploicae will be seen throughout. So it's not actually considered as a guide. The answer is anterior tinea coli. So can you see the tinea coli? So this is the appendix, and this is a point where all the three tinea coli will be meeting. So when you open the abdominal cavity, you will be seeing the anterior tinea coli. It will be easy to identify the anterior tinea coli, and if you trace it towards the end, that will lead you to the appendix. Okay, and this is actually a retrocecal vermiform appendix. The three tinea coli will be actually merging at the root of appendix. That is how you identify it. Though appendix is considered as a part of large intestine, it is devoid of all the three main features, like it is devoid of tinea coli, it is devoid of saculations, it is also devoid of appendices epiploicae. Apart from appendix, rectum is also not having all these features, though they are considered as belonging to the large intestine. So that also you have to remember. Very, very important. Now we have already discussed which is not a feature of colon. Tinea coli, appendices epiploicae, castrations, valvulae conjuventus. Can someone answer this? Not a feature. Can someone answer this? Can someone answer? Yes. But can you say what do you mean by valvulae conjuventus? It's easy to identify because it's not there among the three important features, cardinal features of large intestine. But can you say what do you mean by that? Yes. So some of you were answering it correctly. Valvulae conjuventus is nothing but the plica circularis or valves of Kerckring. Okay. Now coming to the next question. Sorry, structure related to the apex of the sigmoid colon. If you haven't seen the answer, can you try answering it? Structure related to the apex of the sigmoid mesocolon. What is the answer? Apex of sigmoid mesocolon. The answer here is left ureter. Very good. So you can see the sigmoid mesocolon. It has got an apex, and you can see the structure related is left ureter. And what are the contents of the sigmoid mesocolon? Can someone answer the contents of the sigmoid mesocolon? You have the inferior mesenteric artery and superior rectal artery. Okay, so that also you have to keep in mind. Inferior mesenteric artery and superior rectal artery. The arteries related to sigmoid mesocolon. Now, coming to the next question, what is the most fixed part of the urinary bladder, whether it is apex, neck, body, or base? Can I get the answer for this? Whether it is apex, neck, body, or base. The answer is neck. So, the first one is actually an image of a male bladder and its relation, and the second one is actually an image of a female. So you can see the neck at both these regions, and they are considered as the most fixed portion, and it is connected to the pubic bone through the pubio-prostatic ligament in case of males, and in the females you can see the pubovesical ligament related to it. And what do you mean by physiological neck? So anatomical neck is the most dependent position of the bladder, and it is the point which is in continuity with the urethra. What do you mean by physiological neck? Can someone answer? You have the anatomical neck as well as the physiological neck. What's the difference between these two? Anatomical neck, we already mentioned it as the most dependent portion, and actually it is continuous with the urethra. What do you mean by physiological neck? Can someone answer? In females, I have mentioned it as female urethra, the entire female urethra. But in case of males, I have mentioned it as prostatic urethra. So what do you mean by physiological neck? How will you explain physiological neck? Can someone answer it? Physiological neck means it is that part which is having the detrusor muscle continuity. So in case of females, the detrusor muscle is actually continuing throughout the female urethra, whereas in males, it is actually only up to the prostatic urethra. So that part of the urethra which is having the detrusor muscle continuity, that is considered as the physiological neck. Okay. Now the next question, following abdominal surgery, a 65-year-old man experiences a tingling of the skin around his umbilicus. Which of the following nerves is most likely causing this symptom? It's very easy. We all know the dermatomal levels of the anterior abdominal wall. The options are 10th intercostal nerve, subcostal nerve, ilioinguinal nerve, iliohypogastric nerve. Yes, we all know it. Clinically also we assess the levels, right? So it is the 10th intercostal nerve. So this is how you get the dermatomes, and around the umbilicus you have the level of T10. 34-year-old at 28 weeks gestation has internal hemorrhoids. Enlargement of the normal anastomotic connections between the tributaries of Inferior mesenteric vein and those of which of the following vein contributed to the development of this problem? So the question might look complicated. It is a hemorrhoid. So between the two systems, portal and vena cava system. One we already have, that is the inferior mesenteric vein. Inferior mesenteric vein belong to which system? Vena cava system or portal system? Inferior mesenteric vein belongs to? Please think and answer. Inferior mesenteric vein belongs to which? Portal, isn't it? Inferior mesenteric vein is draining into where? Inferior mesenteric vein, though not forming portal vein, it is draining into, we already discussed all these points, right? Inferior mesenteric vein, yeah, very good. No. Somebody is answering it wrongly. Inferior mesenteric vein draining into, when we discussed the formation of portal vein, superior mesenteric vein and splenic vein, there we mentioned the inferior mesenteric vein. Yes, splenic vein, very good. So we need to find out which is the vein belonging to the vena cava system causing this hemorrhoid. The answer here is internal pudendal vein. Let's see how it is. Okay, so this is the inferior mesenteric vein and superior rectal vein. The other veins are middle rectal and inferior rectal. So when you consider this inferior rectal, it is actually a tributary of internal pudendal vein. Okay, which is actually in turn a tributary of internal iliac vein, and finally it will be belonging to the vena cava system. So it is not given as inferior rectal vein, but the next vein in the line is actually the internal pudendal vein, which is given here. So which belongs to the caval system. Okay, so that is how you identify. In a hemorrhoid, you will get that portosystemic anastomosis. So portal component they have given as inferior mesenteric vein. The other one, the systemic or the caval system, in the caval system, which is the vein, you have to identify like this. Inferior rectal vein, which is actually a tributary of internal pudendal vein. So sometimes you will get the vein as internal pudendal vein or inferior rectal vein or internal iliac vein. Just try to identify which belongs to the caval system. The middle rectal vein is also a tributary of the internal iliac vein. Now, when we talk about the piles, primary internal piles, you can see the radicals of the superior rectal vein in the anal columns at three important positions: 3 o'clock, 7 o'clock and 11 o'clock. These are the commonest positions where you can look for the primary internal piles. The next is, which of the following maintains the anorectal angle? Can someone answer this? Anorectal angle. All these are favorite questions and they usually ask with images. Yes, most of you know the answer. It is the puborectalis. So puborectalis actually forms like seen like a sling to form the angle. Now the next question is, 60-year-old man is having failure of erection after surgical removal of his rectum. An injury to which of the following nervous structures most likely occurred during the procedure? So you need to know the nerves which are causing erection and ejaculation. So the code which we usually use is point and shoot. Point means erection and shoot is ejaculation. Point P stands for parasympathetic and shoot S stands for sympathetic. So P means parasympathetic, that is erection, and shoot S is sympathetic, that is ejaculation. So sympathetic and parasympathetic are governing the erection and ejaculation. Okay, so here it is erection which is affected. So that means parasympathetic is affected. So among the four options, which is parasympathetic? We have already discussed the parasympathetic component. Can someone answer with this knowledge? Yes, I hope it's clear for you. So the answer is pelvic splanchnic. We discussed about thoracic, lumbar and pelvic splanchnic nerves, out of which only pelvic splanchnic nerves are considered as parasympathetic. Okay, so this is very, very important. Pelvic splanchnic nerves, you have the S2, 3 and 4 components. So there are two important plexuses. One is superior hypogastric plexus and the other one is inferior hypogastric plexus. And you can see there is only one superior hypogastric plexus, whereas there are two inferior hypogastric plexus. An inferior hypogastric plexus is formed by the contribution from superior through hypogastric nerve and also by the union of pelvic splanchnic nerves. So you have two inferior hypogastric plexus on either side, but there is only one superior hypogastric plexus. Hypogastric nerve is actually derived from the superior hypogastric plexus. So I would like to share this slide with you. Very, very important. And you will get a lot of questions from each. So superior hypogastric plexus is otherwise known as presacral nerve. It is actually seen in front of the L5 vertebra below the aortic bifurcation. Whereas inferior hypogastric plexus, you have two in number on either side of the rectum. Superior hypogastric plexus is purely sympathetic, whereas inferior is actually a mixture of sympathetic and parasympathetic. Because we have seen the parasympathetic component as the pelvic splanchnic nerves joining the inferior hypogastric plexus, and the sympathetic component is actually coming through the hypogastric nerves from the superior hypogastric plexus. So, inferior hypogastric plexus is a mixture of sympathetic and parasympathetic, whereas superior hypogastric plexus is purely sympathetic. And it is derived from the inferior mesenteric and the lumbar splanchnic nerves. And what is it dealing with? It is dealing with the pain from the uterus, bladder, rectum, and whereas the inferior hypogastric plexus is dealing with the micturition and defecation reflex, the parasympathetic reflexes. Now, presacral neurectomy is when you deal with the superior hypogastric plexus, and there it is shoot S. So ejaculation is effective. Hope this concept is clear. From this table itself, you will get questions in all permutations and combinations. Is this concept clear? Can someone say yes or no so that I will get an idea whether you are following? Yes, thank you. Now we'll move to the next part. A 64-year-old woman is diagnosed with carcinoma of the anal canal. At this stage of disease, the neoplasm is located entirely below the pectinate line. To which group of lymph nodes would cells from this neoplasm initially spread? So they are asking the lymphatic shed below the pectinate line, whether it is common iliac, external iliac, internal iliac, superficial inguinal nodes. Pectinate line is actually a lymphatic shed plane. Can someone answer? Can someone answer this? Not getting a correct answer for this. Let's see. It is into the superficial inguinal nodes. So you can see the line of pectin, and above it is going to internal iliac and below it is going to the superficial inguinal nodes. Okay. So that is actually a watershed plane. Now, the pectinate line, it's again a very favorite question, reflects a change in following aspects of the anal canal, except it is considered as a plane of embryological origin, neurovascularity, nature of the epithelium, musculature. What does not change with respect to this line? Can I get an answer? Yes, very good. Most of you know the answer, I think. So musculature, nothing is happening for the musculature. So this is actually the pectinate line, and one more line is there in the anal canal, that is white line of Hilton. So you can say the three parts, that is above the pectinate line, between the pectinate line and white line of Hilton, you call it as pectin, and below the white line. So let's see what are the features which you can get. So embryologically, above the pectinate line, it is derived from endoderm or cloaca, whereas below the pectinate line, it is an ectodermal derivative, proctrudium. Okay. Now, Coming to the neurovascularity, the nerve supply above the pectinate line, you get autonomic nerve supplying it, whereas below the pectinate line, it is the somatic nerve, especially the pudendal nerve. Artery, above, you have the superior rectal, and below you have the inferior rectal. Superior rectal, you know, it is a branch of inferior mesenteric, whereas inferior rectal is a branch of internal pudendal. Coming to the veins, superior rectal veins belong to the portal system, whereas inferior rectal veins belong to system A. Then above, internal iliac nodes, below, superficial inguinal nodes. This was the question which we were discussing. And coming to the epithelium, above you have simple columnar, and below, since it's ectodermal, it is stratified squamous. So this is again a very favorite question. For most of the exams, you will get all sort of options from this tabular column. Now, per rectal examination in males helps to palpate the following except. When you do a per rectal examination in a male, what are the structures which you will be palpating? Prostate, seminal vesicle, urinary bladder, urethra. Except. Which is the exception? Which structure you won't be able to palpate? Yes, someone has answered it correctly. So it is the urethra which you won't be able to palpate. Okay, so the bladder, the rectum, seminal vesicles, all you can palpate, but the other one is prostate, and inside it you get the urethra. So the next question is, up to which rib is right mid-clavicular, in the right mid-clavicular line, the highest point of the right lobe of liver usually extend? Very, very easy question. 5, 6, 7, 8. Can someone answer this? In between, you should get some simple questions so that you will feel like sitting, right? Someone has answered it correctly. It is fifth rib. Okay, so fifth rib actually lies at the maximum convexity. Junction between the anatomical right and left lobes of liver anteriorly. Which structure will you get at the junction of right and left lobe? Yes, again, very easy question. Falciform ligament. You have the falciform ligament which divides the liver into right and left anatomical lobes, and you have choanal segments, 8 choanal segments, and according to the choanal segment, lobe 4 refers to what? Caudate, quadrate, right lobe, left lobe. 4. Somebody has answered it correctly. Someone has gone wrong. It is quadrate. So you can see 1, 2, 3, and 4 in a clockwise manner, and 5, 6, 7, and 8 actually from below upwards. Okay, 1 to 4 above downwards, whereas the other one is in reverse order. And here you can see 1 is caudate and 4 is quadrate. The following statements regarding the gallbladder are true except. It is crossed by subcostal plane. Its neck lies immediately to the right of the epiploic foramen. Fundus is covered with peritoneum on all sides. Enlarged and extrinsic obstruction of the bile duct. Except. One has correctly answered it. It is not the subcostal plane. It is the transpyloric plane where you get the gallbladder. Which of the following forms the left boundary of Calot's triangle or cystic triangle? Visceral surface of liver, cystic duct, common hepatic duct, common bile duct. Most of these structures are related to the triangle. So the question is left boundary. Can I get the answer? Left boundary of Calot's triangle. It is common hepatic duct. So this is the common hepatic duct. This is the cystic duct on the right side. And above you have the visceral surface of liver. And inside, you can see a caterpillar loop. That is known as, can someone say the name of that loop? Particular name is given. It's again a favorite question in, yes, Moynihan's sum. Favorite question in for the surgeons. So that is Moynihan's hum of right hepatic artery in cystic triangle. And another component which you can get, another content which you can get in this triangle is lymph node of Lund. Okay. Select the incorrect statement about the spleen. Long axis corresponds to left 10th rib. It becomes just palpable below the costal margin when enlarged more than twice its normal size. Its inferior border is notched. The left 10th intercostal space near the mid-axillary line is the usual site of splenic puncture. Incorrect. Yes, it's very easy, though other lines look complicated. It is a superior border which is notched, isn't it? So it lies along the 9th, 10th, and 11th rib, and splenic notch is seen in the superior border. You know the Harris dictum of odd numbers, right? It is 1 inch thick, 3 inches wide, 5 inches long, 7 ounces they weigh, and related to 9th to 11th ribs. A 23-year-old woman brought to the casualty with severe abdominal pain following an automobile collision. And after that, she is having severe pain, internal bleeding. Exploratory surgery indicates that the spleen has been damaged severely and it should be repaired. Which of the following structure is most likely to be encountered during this procedure? Inferior mesenteric artery, left suprarenal, left ureter, pancreas. They should be aware of which structure lying in close proximity with the spleen. Usually we say when we do that surgery, that patient will land up in some other diagnosis after the surgery because of the structure lying close to it. Accidental removal of that structure might result in another clinical condition. So can someone say that? I didn't see an answer. The answer is pancreas. So when you remove spleen, when you remove the ligaments, the tail of pancreas is in close proximity with the spleen. And it is in the tail of pancreas you have the islets of Langerhans. So what will happen if you remove the tail of pancreas? After the surgery for removing the spleen, the person will end up as a diabetic. Okay. So that is the importance of the relation. Hence, it is asked so. Now, with this slide, I think we will wind up the session. Abdomen is a vast topic. You need one whole day if you have to discuss the topic. But I will try to finish this off with this slide. Match the following: esophageal opening, aortic opening, vena cava opening, lower limit of right crus, lower limit of left crus. Esophageal opening corresponds to which vertebral level? Can someone say? Aortic opening. It's very easy, isn't it? I will just show you the answer. Esophageal opening is actually 10 thoracic vertebra. Aortic is what? IOA. IOA is the code. Inferior vena cava, esophagus, and aorta. 8, 10, 12. Okay, with this knowledge, you can explain it. Aortic opening is 12. Vena cava is I. Starts with 8. Okay, and lower limit of right crus and left crus. Right crus extends up to third lumbar and left crus extends up to second lumbar. Okay, so you can see IOA 8, 10, and 12. And you can see the right crus extending up to L3 and left crus extending up to L2. So with this slide, I am ending the session.